hypertension, or diabetes. Her family history was significant for only her mother, who was diagnosed with a severe form of multiple sclerosis 2 years ago. According to her complaints, we did a thorough neurological examination which revealed that the patient had a severe loss of vision in her left eye. And with her visual acuity was 20 to 100, and also she heard abnormal afferent pupillar reflex cord marcus scan pupil. But the same abnormalities were not found in the right eye. The patient also underwent fundoscopic examination, which revealed that the retina and retinal blood vessels were normal. The remaining examination was significant only for the hypoesthesia or decreased light touch and pupil cessation over her right side. We referred to this patient to the ophthalmologist who made the diagnosis of optic neuritis. So we also took blood from the patient to exclude all the possible causes that could have the same clinical manifestation. But all the blood tests came back negative. So we did MRI scan, which showed the multiple hyperintense plaque in the periventricular region, as you can see on the MRI. And also in the sagittal plane, the characteristics Dawson's finger were visible. We started the corticosteroid treatment, which the patient responded really well to the treatment and all the symptoms disappeared. But we advised the patient to do the annual neurologic examination because of her family history and all the test results, she had a really high risk of developing multiple sclerosis. She did well for approximately 2 years, but then came back to our clinic with another attack. She had weakness on her left side, also abnormal gait, slurred speech, and nystagmus. We did the CSF lumbar puncture and CSF analysis, which showed that the patient was positive for the oligoclonal bands. So we did a repeat MRI scan, which showed there were new lesions in the pons in the middle cerebral peduncle. As we have seen from the case, the multiple sclerosis is a very complex disease, so a thorough knowledge of its pathogenesis is essential for physicians to make the correct diagnosis. So my colleague will now talk about the pathogenesis.
Pathogenesis of the multiple sclerosis can be divided into 4 main parts. This is activation of T lymphocytes, then migration across the blood-brain barrier, then initiating the inflammatory response, and ultimately demyelination and neural degeneration. First, for activation of T cells, the autoantigen must cross blood-barrier caused by certain neural damage, which would damage the blood-brain barrier integrity and cause to leak certain proteins like myelin basic protein or myelin oligodendrocyte glycoprotein. After that, these proteins are absorbed by the APCs, antigen-presenting cells like macrophages, then processed and presented to the T cells. So then these T cells are activated and differentiate to Th1 and Th17 cells and start to migrate to the neural tissue. Here you can see the rolling process of the T cells, and by help of the certain adhesion molecules, integrin alpha 4 beta 1, they adhere to the blood-brain barrier endothelium cells and then produce certain metal proteases which degrade tight junctions between endothelial cells and cross the blood-brain barrier and enter neural tissue. Then they re-encounter the same antigen they met before and activate microglia and also produce certain cytokines like TNF gamma, alpha, interleukin 2, interleukin 1, interleukin 12, and others. These cytokines also activate macrophages and B cells, and B cells are attracted as well, which produce autoantibodies, which damage the myelin and oligodendrocytes, and also macrophages and also microglia produce proteases and other reactocytogen species which degrade myelin and destroy the neural tissue. Here's a little animation which sums up the pathogenesis of the multiple sclerosis. Here you can see already damaged neural tissue, but in this animation, it's a little bit slow, but here it will show the normal oligodendrocyte, how it myelinates the axon. Here you can see oligodendrocyte, which myelinates axon. And now, in the circulation, while the APC has already is presenting the T cell, the antigen is activating T cell, then this T cell produces certain cytokines which activate other inflammatory cells like B cell and macrophage. Then here you can see how it crosses blood-brain barrier by alpha-4 integrin. And here it re-encounters the same antigen and produces other cytokines and activates other cells, B cells, microglia, and macrophages. And here you can see that B cells produce autoantibodies which attack oligodendrocytes in myelin and ultimately destroy them. And also here is a macrophage which devours by help of proteases and reactive oxygen species the myelin. On the location of the damage depends the symptoms of the patient, and it could be sensory or motor. Now about etiology, there are several predisposition factors to the multiple sclerosis, which are female gender, and multiple sclerosis is most frequently seen in ages between 20 and 40. And there's patients who are living in the non-equatorial regions, like southernmost and northernmost regions. They have higher risk for multiple sclerosis. Also, mutations and deformities in HLA-DR2 and HLA-DRB1 is associated risk, and also vitamin D deficiency. And there are several triggers which initiate this process for the autoantigens and the merely basic proteins and other proteins to enter the circulation. There is needed triggers, which could be viral, bacterial, or toxic chemical, anything that could damage integrity of blood-brain barrier and cause the neural proteins to enter the circulation, could be a risk of development of multiple sclerosis. There are several hypotheses of pathogenesis of the multiple sclerosis, and one of them is defect in the negative selection. Here you can see while there is a antigen presented to the T cells, they undergo apoptosis while it works normally. But in case of diseases, syndromes like autoimmune polyglandular syndrome, you can see that there is a defect in IRE gene. While the self-antigen is presented to the T cells, they don't undergo apoptosis, and that's why they are autoreactive. Hypothesis says in this hypothesis there could be defect in this mechanism, but not in the same gene, but which would affect the negative selection. The pathogenesis perfectly correlates with the symptoms of the multiple sclerosis, so it's very important to understand pathogenesis for the diagnosis and treatment.
As my colleague already mentioned, the MS has a variable clinical manifestation, so making a diagnosis can be quite challenging. So usually for diagnosis we depend on two main factors. First are clinical findings, and second are our test results. Clinically, MS is divided into four main types, but the most common type is remitting relapsing, which, as my colleague already mentioned, is usually found in the young female patients. Clinical manifestations are variable, and most commonly found are, for example, numbness and tingling in the 63% of patients, walking difficulty in the 48%, vision problems in the 40%, etc. In the past, making diagnosis required usually the two separate neurologic attacks, which were separated in time and space. But nowadays, with the help of the McDonald's diagnostic criteria, we are able to make the diagnosis of MS even after the first attack. The second factor that helps us make the diagnosis are our test results. First of all, I want to talk about the MRI, which is the golden standard imaging study for MS, because it shows us all these demyelination plaques, which are usually found in the subventricular regions, as you can see on the B, for example, or D picture, or in the, for example, in brainstem, in cerebellum, or even in the spinal cord. The second test, which helps us make the diagnosis, is CSF analysis. In the CSF analysis, we can see that the 90 to 95% of MS patients are usually positive for oligoclonal bands. But remember that this is not specific for MS, because other disorders can also have oligoclonal bands. And the third diagnostic mechanism is evoked potentials. Usually in MS, when there's demyelination, CNS response is delayed to the peripheral stimuli. So we can use, there are three different evoked potential tests, such as visually, auditory, or somatosensory, which all show that in MS, the response of CNS is delayed to the peripheral stimuli. Now, treatment is also quite challenging because unfortunately there is no cure for MS nowadays, but there are a lot of new drugs that are undergoing clinical trial, so there are some very promising ones. But now I want to focus on the treatment that is available for us. First, we focus on to speed the recovery from the attack. For this type of treatment, we usually use glucocorticoids such as oral prednisolone or intravenous methylprednisolone, or if the patient does not respond to this treatment, we can use plasmapheresis. The second line of treatment, these are called disease-modifying drugs, which slow the progression and also decrease the rate of relapses. And here I want to emphasize the one drug, natalizumab, which is the monoclonal antibody, which is against the alpha-4 integrin, which my colleague already said, that helps transportations of T cells into the CNS. And also there are new per-oral drugs, which are more convenient for the patients because the previous drugs usually are administered intravenously or subcutaneously or intramuscularly, which is not that convenient for the patient. So these new drugs are very good for the patients. And the third line of treatment is symptomatic because, as we have already mentioned several times, MS has variable clinical manifestations and some of the symptoms can be quite inconvenient. For example, fatigue, we can use for fatigue amantadine or modafinil or bremolin, or muscle spasms, which is quite painful, so baclofen can be used for that treatment. All these available treatment, even though cannot cure the MS, they have a good, they slow the progression. So MS patients, even though they may have disabilities, they live long. Their life expectancy is only 6 years less than for patients who does not have MS. So this is only the small part of the information that is available for MS. And thank you for your attention. And if you have any questions.